Hello, just wanted to have a little discussion on the angle of pull and spinal distraction. So this will include both lumbar as well as cervical. And the reason for this is I often get questions as to what's the best angle to pull somebody at for a certain type of condition. Let me start by saying that we don't know. And the reason is that this is more of a biomechanical concept, and a good one at that. However, there's really not a lot of conclusive information out there, and I say really not a lot. There's basically none, and so we don't have any clinical indications that I should force a patient into any specific position with regards to how I should pull them, with an axial pull. And that's not to discredit the use of an angle of pull. I do use it myself, but may not be just for these specific reasons that sort of outline the potential biomechanical outcomes. So related to that, we want to keep a few things in mind. One is that there's multiple segments involved regardless of the area that you're actually pulling on. So when you're pulling on someone's head to get to C5, C6, you have to go through all of those segments to do that. So it's kind of like the links in a chain. So you have to start at the beginning for most of our devices anyway, so you really don't have any choice in the matter. So even though we're trying to create some degree of specificity, so to speak, and that's one indication as to why someone may want to choose a specific angle is to influence a segment more specifically. However, it's almost impossible to do that, really, because of the contact points that we make, either at the base of the occiput or at the pelvis, and so really difficult to single out any specific segment. So I put in here that cervical is more affected by the angle, and mostly that's because a lot of the designs for cervical distraction, whether it be mechanical, pneumatic, and even your hands, manual for that matter, really, we position the patient's cervical spine with their head relative to their torso. So the angle of pull is often completely axial. In other words, it's axial to the spine itself, or at least the upper segments and the occiput. So what we do is we adjust the device itself. One particular exception will be the over the head pulley system. So if you're using a weight or a bag of water, you use the angle of the pulling system to potentially influence, and so that's a little bit more similar to what some of us have in the lumbar region, which is going to be a line pulleyed system. So that's why I say for the most part cervical is more affected by the angle. So why does this even work? Well, it's a physics principle, and so it's creating a tangential moment of pull. It's yanking on something at a specific angle relative to the curvature or lack of curvature. So a tangent in this case to a circle it's a line that intersects one point upon that circle that is 90 degrees off of the radius of that circle. Now, that's not necessarily going to happen in the spine, but keep in mind a tangent could also be off of a hyperbola, parabola, any curvature for that matter. So really, the tangent is going to be linear based on a curvilinear object, and in this case, we're creating a vector of distraction force, and that's what that tangent is essentially. So when we look at, and this is easier to do in the cervical spine, just because there's not as much structure involved and so on and so forth, but certainly it's the same concept in the lumbar spine. So what we see is we change the degree. Now when it comes to, like I said, most devices we're going to change the head relative to the torso, which usually includes the position of the device that we're using to attach to the base of the occiput itself. So in other words, we are reducing the lordotic curve to essentially do that, and Wong had done this and was able to evaluate where that high degree moment of pull is going to be in the cervical spine relative to the lordotic curve. So at 0 to 5 degrees of distraction force, it's going to be the upper, and that makes kind of sense. And again, that doesn't mean that we can't get to those lower segments. It really just means that you probably just have to pull a little bit harder. And then as we get all the way down, and I'll skip down to the bottom here, and we look at 25 to 35 degrees, we see that we're at the base of the cervical spine and the superior portion of the thoracic spine. But again, remember that even if I force that patient into 35 degrees of cervical flexion, I'm still pulling on their occiput, so you're still going through the upper cervical spine to get all the way down to the lower cervical spine. And if that's uncomfortable for your patient, even though they, let's say, have a C7T1 pathology, you may want to rethink why you're going to put someone into that specific position. But that's the information, and that's the biomechanical nature of influencing the cervical spine. It's very similar in the lumbar spine. Now, some differences will be kind of like if you were using a line pulleyed system like the over-the-head door system versus a secured system like a Saunders device. In the lumbar region, if you're using a line pulleyed system, that would be in comparison to a motorized table system. In other words, where you strap the patient to a table and the table actually moves itself, versus the line pulleyed system is where you strap the patient and attach them to a device. In this case, it's going to be more inferior to the patient, to pull on the patient's pelvis, in this case, to create distraction relative to the lumbar spine. And so we find that there are some similarities in where I can actually change the patient's pelvic position. Usually we change the pelvic position by changing the iliofemoral joint, the hip joint. Now that's not always the case, so I need to take that in consideration, that just when I flex up that iliofemoral joint, I may not have that much influence on the pelvis, especially if they're blocked in someplace for whatever reason. And I'll show you a picture here in a moment here. But we know that when we start to put the patient into a hip flex position, which we also refer to as the hook lying position, the reason for doing that is it reduces the lordotic curve, and that's the relationship between the iliofemoral joint and the lumbar spine. Technically, it's the relationship between the pelvis and the lumbar spine that creates that degree of reduction in the lordotic curve. So if you perform an anterior pelvic tilt, you get extension or increase in the lordotic curve, and if you produce a posterior pelvic tilt of the pelvis, then you, relatively speaking to the lumbar spine, then you get a reduction in the lumbar lordosis or flexion of that spine. So typically when we are doing a supine position, that's what we're doing, is we're creating a posterior pelvic tilt, and that posterior pelvic tilt relative to the torso thereby reduces the lordotic curve. Now, for me, this is my go-to, and the reason is because it opens up the posterior elements, and that's not an opinion. That's quite well established, and so it takes up slack in that connective tissue. In particular, it takes up slack in the musculature, which is what we need to go through before we actually get to the connective tissue, and certainly the intervertebral discs. So the benefit of this is it actually reduces compressive forces and thereby can reduce the amount of tension necessary or distraction force that would be required to create some degree of separation, or if you're attempting to perform so, decompression or creating negative intradiscal pressure. And we've seen this in other studies, and probably Ramos and Martin is a really good one to consider in 1994, where they had patients going into negative even before they started creating distraction force. So to me, that's a huge benefit of this. So we accomplish that two ways, and so you'll notice here that there's a pelvic tilt on this table. So the cool thing about that, and if you don't have that, if you're using wedges, for example, in orthopedic blocking, you can create a posterior shift in the pelvis without necessarily lifting up the femur. If you remember, some of the older devices used to come with a stool that you would put on top, and you can create 90 degrees of hip flexion and 90 degrees at the knee. The problem was that actually, because it now put the entire femur, and each leg is approximately 18% of your body, so that creates a high degree of posterior shift in the lumbar spine, which may or may not be good for your patient depending on what it is that you wanted to accomplish. So I like this position best, and I actually use these particular bolsters too. So it puts most patients somewhere between 30 and 45 degrees of hip flexion. So if we look back at this slide right here, you'll notice that degree actually influences the lower lumbar spine. Well, why do I also do it? Well, it also puts and I turn these out a little bit, so it puts the patient into open back position of the iliofemoral joint, basically Faber's position, and it's really important to me that I reduce any tension on the psoas major muscle if I'm trying to perform lumbar distraction, and that could be a discussion for another day. So that's how you can influence that lumbar spine even before, and so if you just wanted to pull straight distraction on that, and that's essentially what happens when you use a treatment table that's motorized, is you influence the patient's position and then you create distraction. Well, the benefit of the line pull lead system is we get to do something like this, and so what happens is we have multiple vectors going on by dropping the table and creating some asymmetry in the way that it creates a distraction moment of force from the patient as a result of the belting system. So what we see in this upper picture, the table's been dropped, so there's a high degree of angulation here. If you just look at the pulley system coming out of the machine itself. What does that mean? Well, when we look at the belting system is attached close to the table and away from the table. And what happens is this O-ring right here is movable. So as you drop this table down, so this is in a fairly straight line pull, not quite, but as you drop it down, there's an increase in the angulation here. What happens is that O-ring moves. So this portion further away from the table actually starts to shorten. And if you shorten a moment arm, then it has a lower degree of force distraction. So it actually reduces the force of that particular vector. Versus down here, these two portions of the belting system that are attached to the patient are much more equal. So what that means is as it pulls away from the patient, that distribution of distraction force is going to be equal close to the table and far away from the table. In this case, there's going to be a high degree of distraction created closer to the table and a little bit less in the portion away from the table. Well, what does that mean? Well, as a result of that, we actually get a coupled motion effect. And that's why I like my pulleyed system table better than my motorized table. Is the primary vector is always going to be axial. It's always going to be distracting away from the patient. But when I create this asymmetry in the distraction force, I get this coupled motion effect. So when the patient is in this prone position, we get an anterior pelvic tilt. But when the patient is in the supine position, we actually get a posterior pelvic tilt. So you can consider that and think about what it is that you would want to accomplish, and that may help you decide, first off, what position to put the patient in. So if you wanted to open up the lateral canal and the posterior elements more so, then you would choose to put them in the supine position. So, and then it enhances that as you create a further angle with the pulley system here, and it's the complete opposite in the prone position. But again, the cool thing is that it's always going to be axial, so the primary vector is going to be in axial. But can you overdo it? Yeah, especially in a motorized table, and especially in the cervical spine. And how much do we need? Like I said, we don't know. This is much more biomechanical. I think we can adapt it, and you can consider, and if you look at reasoning and what it is that you would like to accomplish, the reason for the line pulleyed system as my favorite or my go-to is because it creates that coupled motion effect, and I find that patients really find it comfortable. Well, I hope this was helpful, and we'll see you next time.